A very warm welcome to one and all for another wonderful session of cardiothoracic radiology. Um, so I'm JP Panatapura. I'm one of the cardiothoracic radiologists and co-director of AREP. For the beginners, for the first time attendees, I just want to give a very brief history of how this started. So this was idea from Dr. Turpaning, which started in 2021, but we started our first session in 2022. So this is a nonprofit, cost-free organization and education program, which we started as an Asian radiology education program for Southeast Asian countries. But then it just grew to global academic radiology education program. It includes from different parts of Middle East, Africa, and Asian countries. So welcome you all for AREP. And so we have a wonderful lecture on mediastinal masses today. Um, just a very quick reminder, at the end of the session, we have a quiz. So please take that quiz and you will have a surprise gift at the end of the month. Um, and also, uh, please fill up the evaluation form at the end of the session. That is required to get the certificate of attendance, please. So I'll hand it over to Dr. Mahmood, who's going to be the moderator for today's session. And Dr. Mahmood is a professor of radiology from Iraq. Over to you, Dr. Mahmood. Thank you.
Thanks, GP. Actually, I'm not a professor, but anyhow, hopefully I will be one. Okay. Hello, guys. Dambash in Kurdish, that's from Iraqi Kurdistan. Today I'm going to be the moderator, and I would like to introduce our valuable guest, Dr. Rachan Madan. She is assistant prof in radiology. She's working in Brigham and Women's Hospital in Boston. She's got her MBBS degree from Maulana Azad Medical College in New Delhi in 1998. Did her residency in diagnostic radiology from 2000 to 2006 in Lady Harding Medical College and Affiliated Hospital, that's also in New Delhi. Did her fellowship for 2 years in thoracic imaging from 2006 to 2008, also in Brigham and Women's Hospital. And she did a brief fellowship in emergency radiology at the same hospital. Then she worked as an instructor in radiology for a year and then became a assistant prof from Harvard Medical School. And she has had many administrative jobs. For example, I will say not all of them. She is the lead of Principal Medical Experience, PC, Medicine Longitudinal Imaging Interpretation from 2012 to 2018 in Harvard Medical School. Since 2019, she is the Assistant Fellowship Director of Thoracic Imaging at Brigham and Women's Hospital. She did have many administrative and community and professional society jobs. She did several editorial activities, and she's an ad hoc reviewer in many of the well-known radiological journals like Indian Journal of Radiology and Imaging, Clinical Radiology, Radiographics, and she is a member of the editorial board in radiology, that is the Corridor of Thoracic Imaging, since 2019. She did have many research and publications. If I go through them, you will miss the lecture, so I will cut short here, and I will hand over to Dr. Madan to start her webinar. Please, Dr. Madan, go on.
Greetings to everyone. I think that IT would be starting the video recording. But hello, everyone.
IT, can we please run the video, please? Sorry for the technical delay, I guess. I guess we could have continued your resume. It would have covered. Are we, Net, you know who's controlling the IT net? Sorry about it. Just give me a second. I just heard that they have some technical difficulties in uploading. It'll be done soon. Sorry for the delay.
Sorry, while we are waiting for the uploading of the video, I just want to tell the attendees that there will be a quiz by the end of the webinar. Hopefully it will be an easy one. And as JP said already, that there will be a prize at the end of this month. Hopefully it will be easy for you to answer. And it will be uploaded after the question and answer session. And good luck for everybody.
Yeah, I guess IT is good to go. Can we have the video, please?
And I just wanted to add that I'll be around for questions at the end of the recording. If anybody has in chat or if there's any other way to send them through, I'd be here. I'm Rachna Madan, a thoracic radiologist and faculty at the Brigham and Women's Hospital in Boston. Let me start by commending and giving kudos to the STR and Academic Radiology Education Program for facilitating this global platform and for inviting me to be a part of this global conclave. Now, the Mediastinal is close to my heart at least, and I find it quite exciting and a lot of fun trying to troubleshoot some problematic cases. So what I would like to do today is share some challenges and pitfalls we face while characterizing some tricky mediastinal masses. I have no disclosures relevant to this presentation, so let's begin. I'd like to start with sharing this case. This was a patient who presented with neurological symptoms, and on imaging, we saw a solid paravertebral mass on the right, and you can see low-level uptake on the PET CT. And just based on the symptoms and the location of this mass, we thought that this was likely a neurogenic tumor and offered a biopsy to confirm, but the biopsy was non-diagnostic. At this point, we added an MRI, and you can see this lesion in the paravertebral region, which also extends into the spinal canal. And there's also a large component in the posterior chest wall, which was completely missed on PET-CT and CT. So based on the imaging appearances on MR, it was briskly enhancing on post-contrast sequences. It was T2 hyperintense, and you can see this extension into the spinal canal. This was actually a complex vascular malformation and was giving rise to neurological symptoms due to vascular steal phenomenon, and this was not a neurogenic tumor. So MRI was the modality of the day, giving us a wealth of information. So with that, let me share the objectives of this session. I'd like to review the International Thymic Malignancy Interest Group classification of the mediastinum, which is based on cross-sectional imaging. We'll look at some mimics of mediastinal masses, those lesions which masquerade as masses, but really are don't-touch lesions. You don't have to take any action for them. And then increase awareness of mediastinal masses that benefit from further characterization with MR and PET-CT, when and why to recommend MR and PET-CT in some patients with mediastinal masses, and then highlight cases where management changes significantly with addition of MR and PET-CT. So let's start with the International Thymic Malignancy Interest Group classification. And if you notice now, the compartments are called prevascular compartment instead of the anterior mediastinal compartment. Consists of thymus and some lymph nodes. The visceral compartment, which was previously called the middle mediastinum and consists of important vascular and non-vascular structures. And the paravertebral space, which was previously the posterior mediastinum and includes the thoracic spine and paravertebral soft tissues. And here the spaces are on CT. They're shaded to just show you where they are. So in pink, you have the prevascular space. In blue, you have the visceral mediastinal compartment. And then in yellow, you have the paravertebral space, which includes the spine and the paravertebral soft tissues. So for most patients, actually, CT does quite well. It localizes the mass to the correct mediastinal compartment. And then for many patients also, you can use CT for tissue characterization. It picks up on macroscopic fat, cystic component, calcification, hemorrhage, hypervascularity, etc., and narrows the differential diagnosis and even achieves specific diagnosis in many patients, thereby aids in decision-making and management. So you can then decide whether this patient needs follow-up, or you want to send tumor markers in another patient, or just send the patient for biopsy or resection. But where CT is less well suited is when you have a lesion which has complex fluid with hemorrhagic or proteinaceous contents of milk of calcium, and then can basically masquerade as a solid lesion, or you're trying to delineate microscopic fat, for instance, in a patient with thymic hyperplasia, or look at septations in a cystic mass. So it's in those group of patients where MR is just a superb imaging modality. It has, excellent soft tissue contrast, readily distinguishes cystic from solid lesions on CT, delineates lesion complexity and tissue content in a lot of detail, as I mentioned. It can pick up on the proteinaceous and hemorrhagic material, microscopic fat, septations. Very subtle and delayed enhancement can also be picked up on MR, and so can be necrosis. So the crux of the matter is, when and where do we recommend MR and PET-CT? When is it likely to be a game changer? And those are the masses which we want to highlight. So we want to pick and add these modalities where adding MR or PET-CT would definitely avoid surgery or biopsy, or adding these modalities suggests a specific alternative diagnosis, or with the help of these modalities, you can pick up multiple identical or related lesions with similar signal intensity and enhancement characteristics. Now, this is a little simplistic, but I find it quite helpful. Most problematic mediastinal masses will fall into one of four compartments. So either you would have a hyperattenuating mass on contrast CT or non-contrast CT, which then could be either a cyst with hemorrhagic or proteinaceous contents, or it could be a solid tumor, so very important to distinguish between those two entities. Or you may have a complex cystic mass with equivocal solid component and septations, so we're not sure if it's benign or malignant. And then frequently you have patients with indeterminate thymic enlargement. It could be hyperplasia with atypical morphology, or it could be a complex cyst or multiple cysts within the thymus, or it could be a cystic neoplasm, or a combination of neoplasm and hyperplasia. And last, you may have multiple intrathoracic lesions, and you don't know if they're related to each other or unrelated. So before going further into cases, I just want to quickly refresh with what's really in the non-vascular chest MR toolkit. And this is what are the building blocks of our mediastinal mass protocol. So we perform tissue characterization with T1 and T2 weighted sequences, picking up on fat, fluid, hemorrhage, and myxoid components. Then we do post-contrast sequences, which include both a 1-minute sequence and also, we acquire images at 5 minutes to pick up on enhancing soft tissue component and necrosis. Now, if the mass is in close proximity to large vessels or to cardiac chambers, then it's quite helpful to also think of adding gated dark blood sequences like double inversion recovery or HACE sequence, just to see if there's any intravascular or intracardiac extension. But just know that this adds to imaging time, so you don't have to add it in every single case that you do for mediastinal masses. And one sequence which is actually helpful in almost all the cases that we do is the subtraction sequence, which is really done at the console. There's no additional imaging time required for this, and really allows you to assess for true enhancing component, especially in lesions which have intrinsic T1 hyperintensity due to the presence of either hemorrhage, protein, or tumor. So now a quick general word about PET-CT. And we know that PET is used, it has a very well-established role when we have a patient with lymphoma, but the usefulness is quite controversial when we are trying to characterize a mediastinal mass or trying to differentiate benign versus malignant masses. And the reason is that many benign non-neoplastic entities are also avid, leading to false positives. So for instance, patients with thymic hyperplasia or fibrosing mediastinitis, nodal involvement by sarcoid or schwannomas can all show very high uptake on PET-CT. There's also significant overlap between the SUV values in benign and malignant neoplasm. So thymomas, lymphomas, germ cell tumors, paragangliomas can all show very variable, overlapping SUV values. Now, if we look at thymic epithelial neoplasms, PET can be used to distinguish high-risk thymomas from low-risk thymomas, because high-risk thymomas are associated with higher uptake, and certain groups have come up with some ratios which might be helpful. So if you calculate the SUV max values in the tumor, compare that to the mediastinal blood pool, and if the ratio is quite high, approaching 3, that differentiates between a high-risk and a low-risk thymoma. It's kind of like doing a metabolic biopsy. And if you look at neurogenic tumors, so the scene is a little different. Both schwannomas and malignant nursery tumors have high uptake. So PET-CT is a little non-discriminatory and not too helpful. while neurofibromas, on the other hand, have lower uptake, and you can use PET-CT to distinguish malignant nerve sheath tumors and neurofibromas with higher accuracy. So moving on to our first scenario, which is when you're trying to distinguish between a cyst or a solid tumor. And this happens more frequently in certain regions of the mediastinum. When the likelihood of something being a cyst is higher, there is a lower threshold to order MRI. So one of the most frequent scenarios you might encounter is a prevascular mass. Now, this was a young woman who had chest pain and was getting a PECT angiogram. And while acquiring these acquisition images, bolus tracking images from the PECT angiogram, you can see the patient has what seems to be like a solid-looking, well-circumscribed, non-calcified mass in the prevascular space. And on these bolus tracking images alone, like this is relatively non-contrast and this is post-contrast, you can see that the enhancement is indeterminate. So is this a benign cyst or a neoplasm? So our choices are to bring this patient back for imaging follow-up or send her for surgical resection, or could we troubleshoot this with a chest MRI? So in this case, we did an MRI, and you can see there is a unilocular cyst, which is hypointense on T1 and briskly hyperintense on T2, thin imperceptible wall on post-contrast images, and no enhancement on subtraction images. So MR is able to characterize this as a benign unilocular thymic cyst and averts further imaging studies like PET-CT, which have high radiation dose and also unnecessary surgery. Now, this was a patient referred to thoracic surgery for sampling of what were called necrotic nodes on an outside study. So this was called necrotic paraiotic adenopathy. And as the surgeon was reviewing these images with me, I felt they were really low attenuation and seemed to be quite close to the pericardial recesses surrounding the pulmonary artery. And I actually thought these were pericardial diverticulae, but the surgeon was a little hesitant and nervous because the patient was already booked for the OR for sampling of these necrotic nodes, so to say. And so I said, let's just add additional imaging. And in this case, we did MRI, which showed fluid signal within these lesions and no enhancement. And they were actually communicating with the pericardium. So again, with addition of one more imaging modality, we are able to characterize these as benign pericardial diverticulae, which can frequently mimic mediastinal nodes or adenopathy. And if you recognize this entity, you can definitely avoid unnecessary surgery or imaging workup in young patients. Now, moving on to complex cystic masses, and really MR has a lot to offer here and parse out these lesions and fine-tune the differential diagnosis. So this was also a young woman who presented with a subcarinal lobulated cystic mass insinuating between adjacent structures. And here, the presence of solid component or septation was quite equivocal. So with this imaging appearance and this location, the differential diagnosis included a cystic lymphangioma, bronchogenic cyst, pericardial collection, and a necrotic mass. So really, that's a very wide differential to be useful. So we need to fine-tune this. In this case, we added an MR, which showed that this was indeed a multiloculated cystic lesion with thin septations. And so most likely this was a cystic lymphangioma. So this addition of or identification of septations in this patient was really key to nailing the diagnosis and refining it. And so the patient could undergo cyst aspiration and marsupialization. Now, this was another young patient who presented with chest pain, and on CT we saw a solid appearing mass with calcifications, but also several hypoattenuating foci. And we weren't sure if this were due to the presence of fat or necrosis, or was this streak artifact emanating from contrast in the SVC. So again, added MRI to troubleshoot, and it showed the presence of macroscopic fat. You can see this T1 hyperintensity India ink artifact. And then on the T2 weighted images, you can see a very striking cystic component and thick septations going from wall to wall, which are enhancing on post-contrast imaging. So the constellation of MR findings is quite classic. You have a significant cystic component, thick enhancing septations in solid tissue, and macroscopic fat, which really excludes any other cause of a cystic anterior mediastinal mass in a young patient. So lymphoma and thymic epithelial neoplasms can have cystic degeneration, but it's very unusual, atypical to have septations in these lesions. Now, here was another patient who presented with a solid cystic mass, and this was quite indeterminate. We weren't sure if this was a cyst which had bled and had either clot or debris, or this was a tumor with cystic degeneration. Now, in this case, for whatever reason, MR was not done and they went straight for PET-CT. And this was quite avid with an SUV value of 6. So this was quite suggestive of an aggressive tumor and turned out to be a type B3 thymoma with cystic degeneration. So cystic changes can be seen in thymoma in up to 40% cases, and the tumor may manifest either as a mural nodule, or you can see a dominant eccentric mass or scattered solid components, as you see in this case. So while we are discussing thymic epithelial neoplasm, let me introduce the concept of low-risk versus high-risk thymomas, which can sometimes be distinguished based on their imaging features as well. So the low-risk thymomas usually have a well-defined contour. You can see the capsule or a fibrous septum, and they show homogeneous enhancement. On the other hand, the high-risk thymomas or thymic carcinomas will typically have a more lobulated or irregular contour, presence of calcification, heterogeneous enhancement, hemorrhage or cystic component. They'll also show more invasive features with invasion of great vessels, lymphadenopathy, and pleural and pericardial spread. And there is a strong association between the histologic subtype, invasiveness, and prognosis. So the low-risk thymomas can straight away go for surgical resection, whereas the high-risk group, which are typically the B2 and B3 thymomas and some neuroendocrine tumors, are more invasive and have lower survival rates and higher rates of recurrence. And these patients really benefit from neoadjuvant chemoradiation for local control of disease before going for surgical resection. So here's a very nice example of a low-risk thymoma. This is an off-midline mass, very well circumscribed, homogeneously enhancing, not too lobulated, not too heterogeneous. We don't really see any necrosis, hemorrhage, or calcification. And then on PET, we saw just very mild uptake, similar to blood pool, similar to background, and this was a type A thymoma. And this patient, even though this is a non-contrast CT, you can see seems to be much more lobulated. There are several fronts of invasion into the mediastinum. So it's invading the fat, there's calcification, and then more inferiorly, you can see invasion of the pericardium with small loculated effusion and some solid nodules. And then inferiorly, you can also see some implants along the left diaphragmatic pleura. So very classic of spread of thymoma with dry pleural disease and pericardial invasion. And this is the PET-CT for the same patient, showing much more higher uptake compared to the low-risk thymoma. And you can also see the drop metastasis involving the diaphragmatic pleura, the dry pleural disease. So this was a case of type B3 thymoma and stage 4A disease in a patient with high-risk thymoma. Now, this was a patient who presented with syncopal attack, and you'll see why in a second. So very aggressive looking prevascular mass, which you can see is invading the superior vena cava with tumor thrombus. And as I show you more images on this case, you can see it's also encasing the coronary artery grafts. So this was, a patient with thymic carcinoma. There was involvement of the pericardium, right atrium, ascending aorta. And so the patient underwent neoadjuvant chemoradiation. And then finally, the tumor was resected with the patient on bypass. So our next scenario is when you have a hyperattenuating mass on CT. And a mass can be hyperattenuating on CT for a few different reasons, as you'll see. Either the mass is hypercellular, which happens in patients with lymphoma, and you'll see homogeneous attenuation, and the mass will typically show mild to moderate enhancement. Or you may have a hypervascular mass, which happens with paragangliomas or Castleman's disease, and you typically see brisk and avid and intense enhancement. Or you can have cysts with complex contents, such as hematomas or foregut duplication cysts, or cysts with hemorrhagic or proteinaceous contents or milk of calcium, or sometimes tumors with cystic change. And these are the lesions which would have typically more equivocal or indeterminate enhancement. And these are the lesions which actually benefit most with addition of MRI. So here's a patient who presented with a very well-circumscribed, round, relatively hyperattenuating mass in the subcarinal region. And the attenuation values are about 65 Hounsfield units, similar to the skeletal muscles, similar to the liver. And there's no adenopathy elsewhere. And so the differential for something like this could be a solid mass like due to leiomyoma or a fibrous tumor, or this could be a large lymph node, versus we know that, sometimes foregut duplication cysts can occur in this location and they can have complex contents. So how do we settle this? In this case, we added an MRI, and you can see it's uniformly hyperintense on T1, mildly hyperintense on T2 with shading artifact, which is very helpful, and no enhancing component on post-contrast images and subtraction images. And so this was a bronchogenic cyst with milk of calcium with proteinaceous or hemorrhagic contents. So MR has allowed you to characterize this accurately as an acellular foregut duplication cyst and not a solid tumor. And this case also highlights some of the MR imaging features of complex cysts, which is the presence of T1 hyperintensity, mildly hyperintense signal on T2 with shading artifact, and on post-contrast, you may see post-contrast T1 weighted images, you may see pseudo-enhancement, and it's really, you nail the diagnosis on subtraction sequences, which shows true lack of enhancement amidst intrinsic pre-contrast hyperintensity of these lesions. Now here's another patient, almost a radiological twin, if you will. Same location, subcarinal station, and you have a very large subcarinal mass. So should we assume that this is a bronchogenic cyst, or should we perform more imaging studies? So in this case, actually, a PET CT was done, and you can see this is almost as bright as the sun, really showing a lot of uptake here. The SUV was close to 9. So this really suggests a cellular neoplasm. A cyst cannot have this much uptake. Cysts would typically be photopenic. So the reason I pair these cases together is that many subcarinal hyperdense masses are duplication cysts, but we must prove that with additional imaging such as MRI or PET CT before deciding on no further follow-up or tissue sampling. And if we assume that these are bronchogenic cysts, then you may actually miss aggressive masses like this. Now, this was another patient with a much smaller mass in the same location, and sometimes we may dismiss these as small bronchogenic cysts or small lymph nodes or reactive adenopathy, etc. So in this case, again, PET CT was done, very mild uptake, but if this was an acellular cyst, it should be photopenic, and this showed some uptake. and this was sampled, and it was found to be a gastrointestinal stromal tumor. So definitely had some spindle cells. So really, the correct strategy for these lesions is to add some form of advanced imaging, PET-CT or MR, which allows confident characterization of the lesion as either a solid tumor or a cyst and helps guide further management. Now, this was a patient who actually presented quite acutely, and this was just based on the location of the mass. The patient was taking anticoagulants and had a recent fall from a bike, and then came to the ED with sudden dysphagia and adynophagia. And you can see this mixed density, relatively hyperdense mass posterior to the trachea, and really inseparable from the esophagus, which is, the lumen is almost completely effaced. So the question was, is this a simple hematoma or is this tumor with hemorrhage? And in this case, the surgeons were quite concerned about underlying malignancy. And so both an MR and PET-CT was done, and you can see this has the appearance of an oblong collection with tapering borders and internal septations, and there's no uptake on the PET-CT. So this is really like an evolving intramural esophageal hematoma and completely acellular. So no underlying tissue here. So with the use of both of these modalities, we were able to characterize this as an acellular hematoma rather than a hemorrhagic tumor, and could manage the patient conservatively with no surgical sampling or resection, etc. So we move on to the next category of lesions, which is patients with indeterminate thymic enlargement, which may be due to hyperplasia, presence of tumor, or multiple cysts, or it could even be a combination of all three. And we actually, cannot do too well with CT, but just trying to differentiate between these three sometimes. And so these are the lesions which definitely benefit from further evaluation with MR. Not so much PET-CT, but definitely MRI. So let me show you this with some examples. So this was, again, a woman who had history of chest pain, retrosternal chest pain, and history of lymphocytic mastitis. So first, a breast MR was done, which showed maybe some abnormality in the breast soft tissues, but also showed a retrosternal mass, which then led to a CT. And on CT, we could see that the patient had a rather solid-looking heterogeneous mass in the prevascular region. And then on these images, at least, the enhancement looks indeterminate. It looks solid. So the surgeon was ready to take her to the OR. But as I was looking at these images on coronal views, and I felt that they still have a somewhat retained arrowhead shape, which on coronal images at least, which makes me think of something benign. It looks solid and definitely could be something malignant, but just seeing this quadrangular shape on coronal images makes me also think that we should, broaden the differential to something benign. So I was thinking of hyperplasia. But this differential was very broad and not too helpful, if we're saying hyperplasia, lymphoma, and thymoma in the same breath. So the surgeon didn't know whether he should take this patient for surgical resection, and send her for percutaneous sampling, or should we do something else? So I thought we could investigate this a little bit more with MR, and then let me share the MR images with you. So the lesion was iso to mildly hyperintense on T1, and there was no signal dropout on opposed phase images. So this was not straightforward hyperplasia that I'd been thinking about. And on on T2 weighted images, this was, showed marked hyperintensity with septations. So it's quite cystic looking. And on post-contrast sequences, we saw rim enhancement, peripheral thin rim-like enhancement. There was no solid nodule or mass. So MR was able to characterize this potentially solid looking mass as a multilocular thymic cyst with complex hemorrhagic or proteinaceous contents, and totally excluded other things like a solid mass or hyperplasia. So we didn't stop here, and brought the patient back for more imaging. But even if you were to follow this patient till now, there's a significant change in management from thymectomy to imaging surveillance, which is huge for a young patient. Now, here are some more images on the same patient after 6 months. And you can see now the lesion is much smaller. And these are T1 weighted images. And you can see this is quite hyperintense on T1 and T2 weighted images. And there's a low signal rim on T2 weighted images, which may be hemosiderin or it could be a fibrotic rim. And on post-contrast images, it looks like it's enhancing, but remember that this was bright to begin with. And so on subtraction images, we see there is no enhancing rim or enhancing soft tissue. So it's really the subtraction sequences which confirms lack of any enhancing soft tissue component. So this was a really nice, fascinating case, how MR is able to track evolution of a potentially solid mass on CT to then a complex multilocular thymic cyst on MR. And then when we follow the patient further, this got much smaller and just was a unilocular hemorrhagic thymic cyst. So we followed the patients for 3 years, and by the end of it, she had something like a less than 1 centimeter lesion, which couldn't be seen anymore. So this was very rewarding to see, to avert major surgery in a young patient like this. Now, this is an oft asked question. Are we looking at a case of hyperplasia, or is this tumor? So these are 2 patients with very suggestive history and clinical background. On the left, you have a young patient with a history of myasthenia. On the right, you have a patient in their 50s who is post-chemotherapy, and both have thymic enlargement. So is this hyperplasia or tumor, and why do they look so different? So it turns out that there are 2 types of hyperplasia. So on the left, you're looking at a case of lymphoid hyperplasia with increased number of lymphoid follicles, but the gland does not always have to be enlarged. And this typically happens in patients with autoimmune disease. On the right, you have a case of true hyperplasia where the thymus is, enlarged beyond the upper limit of normal for age, and it typically follows recovery from stress. In this case, it was chemotherapy. So there's rebound hyperplasia. Now, for most cases, CT does well, and this was a nice paper from our institution looking at the CT features of thymic hyperplasia. And in most patients, you will see that the gland is pyramidal in shape, heterogeneous due to the presence of fat and lobules, and calcification is typically absent, and doesn't have like isolated nodules. But what happens when you have, you can have cases where the gland is round or oval or irregular or homogeneous looking, there's no heterogeneity, you can't see fat, macroscopic fat. And so for these kind of cases, MR is really, the way to go to see if this could be thymic hyperplasia. And how do we go about detecting thymic hyperplasia and confirming it? Well, we have a thymic mass MR protocol. And for detection and quantification of microscopic fat, we use dual echo chemical shift MR and axial in and pose phase images, just like you do for characterizing adrenal nodules. And for most patients, actually, visual comparison works quite well. You can see the signal dropout. But in some cases, the dropout is more subtle, and you may have to use, parameters. And so many years ago, Inoka et al. Came up with the chemical shift ratio, which compares the signal intensity of thymus with paraspinal muscle on in-phase and oppose phase images. And then a few years ago, we had the signal intensity index, which was easier to calculate. No normalization with reference tissue was required. And this actually has a pretty high sensitivity and specificity in distinguishing hyperplasia from tumor. So these 2 indices are really helpful to remember. Now, one thing to remember about chemical shift imaging is that it should not be used in isolation to differentiate hyperplasia from tumor. because in many young patients and women in particular, they may have a lipid-poor thymus, which may not suppress on chemical shift imaging. So if it's a very handy and useful tool if used appropriately and correctly, along with other morphological features, see if the enlargement is focal or diffuse, what are the margins, what's the shape, is it pyramidal or round, is there any enhancing tissue, what are the T2 features? So it always is applied in the context of other morphological features. So let's try to troubleshoot with a case. This was a patient who presented with enlarged thymus. And besides the thymic enlargement, we could also see a hyperdense nodule. Now, this could be a small thymic tumor, or it could be a cyst with hemorrhage. And so, MR was added and showed that there was signal dropout in the, entire gland except for this nodule, which did not suppress. But then it also had no enhancement on the post-contrast images. So we said that this was thymic hyperplasia with cyst, and the cyst may have bled a little bit, but the surgeon was a little nervous and went ahead and did a thymectomy anyway. But this was confirmed to be hyperplasia with cyst. Now, another scenario that we come across is when we have multiple lesions and we don't know if they're matching or related to each other or not related. So this is a nice example. This was a man in his 60s presenting with low-grade fever, weight loss, history of prostate cancer, and we saw an infiltrative large soft tissue mass in the posterior mediastinum, which was encasing the esophagus and the carina. So really large, long segment extending from the level of the carina to below the diaphragm. And this was mildly avid, actually, on PET-CT. So it didn't really help with the differential diagnosis. So based on the history and the demographics, we thought this could be lymphoma, could be metastatic disease from the prostate cancer, but then also widen the differential a little bit to, inflammatory or infectious things like mediastinitis or IG4 disease. So at this point, decided to add an MR to see, if we could fine tune it a bit more before sending the patient for tissue sampling. And we actually saw several T2 hyperintense cystic lesions in the posterior mediastinum, which were extending to the level of the upper abdomen. And in the abdomen, we noted, a few peripancreatic fluid collections, pancreatic ductal dilatation, all of which was suggestive of pancreatitis with pseudocyst formation. So this was, as you've guessed by now, posterior mediastinal extension of pancreatic cyst. And I think without the use of MR, you really couldn't have tied these things together. So it really nails the differential, the diagnosis on this one. Now, last, I'd like to just, share some thoughts on hypervascular masses and why they're so important to recognize. Well, the most important reason is that this would, for one, fine-tune and narrow your differential diagnosis to select few entities, as you see in the table below. Usually patients with Castleman's or paraganglioma or metastatic disease from a hypervascular primary, sometimes even neurogenic tumor. And secondly, an important reason to recognize hypervascularity is because it entails a propensity to bleed. And so if you do recognize hypervascularity, do consider pre-op embolization. And if you note that, then open surgical biopsy is a much safer option with better control of hemorrhage than percutaneous biopsy in these patients. So this was a nice example, a woman who had presented with refractory hypertension, palpitations, and flushing, and we see an avidly enhancing mass along the lesser curve of the aorta, which is enhancing just similar to the aorta, numerous feeding vessels. And we also added a cardiac MR, dark blood images, which showed no intravascular tumor. So this was a paraganglioma. And these were two separate patients who had middle mediastinal masses which were stable for several years, almost like a decade. And on the left, you can see some arborizing calcification, and on the right, you can see more, diffuse and strong enhancement. And both actually were enhancing quite a bit. And so these patients were actually taken up for surgical biopsy and not mediastinoscopy just based on the hypervascularity, and that was considered unsafe. And they turned out to be cases of Castleman's disease. And the middle mediastinum just happens to be the most common location. And another thing to just remember about this entity is that it can coexist with other malignancies like lymphoma and Kaposi's. So patients often actually get PET-CT surveillance. Now, this was a patient with a very characteristic history. They presented with acute abdominal pain, pancreatitis, elevated calcium and PTH levels. And you can see a homogeneously enhancing, well-circumscribed anterior mediastinal mass, which also showed uptake on the sestamibi SPECT-CT. It's markedly avid. And so this was, an ectopic intrathymic parathyroid adenoma. And I want to leave you here with this very last case. This patient actually was referred for biopsy of what was thought to be a low anterior mediastinal mass. And while I was reviewing these images, I noted there's a little blush of contrast in the center of this lesion, and I didn't like that. And so while reviewing the images and seeing if we could biopsy this, I went on to look at the sagittal scans, and lo and behold, this was actually intrapericardial. If this was a mass was in the anterior mediastinum or in the prevascular mediastinum, it should be superior to and anterior to the pericardium. But this was actually confined by the pericardium. So sometimes low anterior mediastinal masses, intrapericardial masses can mimic or present like low anterior mediastinal masses. So this actually was an intrapericardial mass in the AV groove and very vascular. And so typically in this location, you get paragangliomas, which are very, very vascular. And so patients can easily have a hemopericardium from the surgical procedure or from any biopsy. And so with that, I would like to thank you for your attention and participation, and I look forward to your questions and comments. Thank you.
Thanks, Dr. Madan. It was really helpful and nice webinar. Well done. And now the door is open for any questions. I believe there are none in our box. So if anybody wants to ask, please write it down and we'll direct it to Dr. Madan.
My pleasure. Thank you for the invitation.
Thanks. So we go to one was already here. It says, Madam, what was the diagnosis and the last case?
That was also actually a paraganglioma in the AV groove. I'm not sure I was audible. That was also a paraganglioma in the AV groove.
Any other questions?
As you saw, the enhancement was very similar. It was very briskly enhancing. And I had shown another case which was along the lesser curve of the aortic arch. And so I don't know if you remember, but the enhancement was very avid, very brisk, and similar for the two cases. And these kind of masses tend to occur along vascular bifurcations and wherever these chemoreceptor bodies are.
Thanks. Any other questions going? If there is none, we would like to thank Dr. Madan for her efforts, and hopefully we'll see her in the next programs, hopefully.
1 second. Sorry,
Okay.
Dr. Mahmood, I had a quick question. Sorry.
Okay,
Great
sorry.
presentation, Dr. Madan. Thank you so much. It was very illustrative, excellent, involving multimodalities, and it showed how MRI is so important in delineating the mediastinal masses. And especially, I really like, I always tell my residents back here in Wake that it is so important to characterize the mediastinum based on the ITMIC classification, the prevascular, visceral, and paravertebral. And also, it goes back to embryology. I have a paper, I have quoted your paper that I know you were an author in the ITMEG classification. Congratulations on that. So it is very important and also it goes back to embryology, right? Like the visceral mesenteric splanchnic layer, which forms all the kind of three layers, which is continuous with the neck and the abdomen, and how the disease spreads from the neck to the mediastinum and then goes to the abdomen and vice versa. So,
Right. No, I think there is such a shift in the way we practice, right? When we only had radiographs, we had the hilum overlay sign and the hilum convergence sign. And
right.
then with widespread use of CT, I think it just kind of made sense that you shift to a classification which is based on cross-sectional imaging. And so I think ITMIC really filled that void. We were all doing it anyways, but we didn't have something solid in place. But then, this kind of made it.
Correct.
And then, I mean, I actually really like CT. It does so well in so many cases.
Yes.
But I think like where we struggle is this solid, is this cystic, especially prevascular and by the esophagus, some foregut duplication cysts. And given that we have the option of using MR, I don't think we need to have those doubts, we can give the patient a clean sheet. This is a cystic lesion, don't touch, and you're good to go. So I think that's where MR really adds value, I think, as well.
And regarding, just had a very quick follow-up question regarding that. You spoke about lymphoid hyperplasia and true thymic hyperplasia. So my first question is there any way to differentiate those both on either CT or MR? And if it is, does it really matter? I mean, it may be just of academic interest, but does it really matter clinically and for the treatment of the patient to differentiate them?
Yes, very good question. And I think this is where a lot of us get stuck, and myself included, even to date, because the thymus is one of those organs which shows a lot of atypical morphologies, and it shows a lot of variation with respect to the size, shape, and at any given age, there are so many different, possibilities, and it's hard to carry that in your head. Now, coming to hyperplasia. So lymphoid, as I may have mentioned in that, is more commonly associated with autoimmune conditions. So younger patients typically, and those who, if they have underlying autoimmune conditions. So the number of follicles may increase, but the gland may still be seemingly be normal in size, but it may be more solid looking. And for those of us who think that, the thymus always should have macroscopic fat, and we don't see the fat, so it could confuse us. So maybe this is an early neoplasm, right? And so then we think, okay, then what do we have by way of troubleshooting this? So we have MR, we have PET CT, and MR, again, just because this is increased number of follicles, not necessarily increased fat, actually your chemical shift imaging may not help in these cases even. So then you see the T2 weighted images. And if you don't see a definite nodule, you don't see cyst, and on the post contrast, you don't see any enhancing nodule or mass, then I think given the context, it's fair to conclude this may be lymphoid hyperplasia and maybe recommend a follow-up MR in 3 to 6 months, just to be sure we're not missing a mass. Now, true hyperplasia, there's really true increase in the size of the gland. And that may be, combination of fat and solid tissue. And sometimes many patients with true hyperplasia may also have cystic change. So that's where actually MR is very helpful. It can show the cystic change. It will show rim enhancement, but no solid enhancing component. Sometimes cysts with hemorrhage, and again can exclude any enhancing nodule or mass within these lesions. So, and this typically occurs, in patients who are recovering from, say, chemotherapy or some stress like surgery, etc. So slightly different patient populations and different imaging appearance. But who would I need to suggest follow-up for? I think the lymphoid hyperplasia, because they don't suppress. And if you definitely want to exclude neoplasm, you may end up recommending a further follow-up MR or CT in those patients because you've not been able to demonstrate macroscopic fat.
Correct. Yeah. Thank you. Thank you so much.
Yeah, no, I
Thank
think
you,
that's
Dr.
why I like
Yes.
it, because it is a little challenging and we have to toil with it a little bit.
Correct.
Okay, thanks, Dr. Madan. Actually, I've got a couple or few more questions, if you don't mind. The first one says, pericardial diverticuli and pericardial cyst, are they the same?
They're used interchangeably. Typically you'll see the most common location of pericardial cyst is right paracardiac region. And the second most common that I found is actually the example that I showed in the paraortic, close to the main pulmonary artery. So as you see, they're clustered or seen close to the pericardium. So I think there was, or maybe sometimes could still be, potential communication. So if with the pericardium, so if a communication exists and they fluctuate in size, it's a diverticulum. If the communication has been closed, then it becomes a cyst. So that's what I'm saying.
Thanks. The other question is, if the thymic tumor involves the pericardium, what is the appropriate modality to confirm that and how to interpret it?
So actually, involvement of the pericardium is actually quite an early feature of especially high-grade thymic epithelial neoplasms. And I have found actually CT does quite well. Sometimes you may not be able to appreciate on axial images, but as soon as you put on your sagittal reconstructions or coronal reconstructions, you should be able to see the superior aspect of the pericardium quite well, where it's close to the ascending aorta and the main pulmonary artery. So you can see early involvement. And that by no means is a surgical contraindication. It just means this is a slightly aggressive tumor. And, the surgeon sometimes may want to do, neoadjuvant chemoradiation to shrink the tumor and have better margins. But these patients can go to the OR even if they have pericardial invasion. And
Thank you. Yeah, one more question. It says, Madam, how do you classify the enhancement into mild, moderate, and intense enhancement?
So I think this is more of a visual thing. I don't have any numbers in mind that I can quote. But if we were to take some examples from the presentation, I think intense were the two masses, the paragangliomas that I showed. It was enhancing similar to a vessel. Mild you would kind of see compared to the muscle, like it's enhancing more to the muscle, and moderate would be somewhere in between. So that's kind of how I would grade it. Really, I think with the technique and your protocols, there's so much variation that it's hard to give you exact numbers. But that's what I would do, like see, is it similar to a vessel? Is it just slightly more than muscle?
Thank you. Actually, the last comment, it's only say, thank you, very informative and clear. So it was not a question, so it was only a compliment. Thanks, Dr. Madan. Thanks for your time.
Thank you.
And yeah, now we are moving to the quiz, guys. So Dr. Madan, thank you again.
I will leave the session. Thank you all. Have a great day. Bye-bye.
Thank you. Thank you.
Bye.
Thank you. Thank you so much.
So guys, the question is very simple, as I've said, and we'll show some images. We'll show the question in 1 minute. And you need to answer it via the QR code that's provided at the end of the quiz. Okay, here we go. I believe you can see. Come on, it doesn't work. Yeah, okay, so you've got 4 images. This is the history. A 30-year-old female underwent PECTA. She was found to have unenhanced hypoattenuating mediastinal masses. And the images are in your right hand. It will stay there for a minute and it will move on. I believe everybody has already known the diagnosis, so I'm not going to wait for the full minute because it's very clear. So the question, oh, somebody has raised his hand. What's going on? Fortunately, cannot take your call because it's a quiz. Sorry, guys. Okay. So the question is, no. So this is the quiz. Okay, so answer this quiz, please use this QR code, scan it, and answer it online. Hopefully you will get it right. Okay. So please do not reply to this webinar. Just go through the QR code and answer there. And thank you very much for your time.
Andrew, has you given the right answer yet?
No, actually, I'm just waiting for them.
Okay. So, okay. Please don't forget.
No, don't
Last
worry
time we
about it.
forget.
No worries. So hopefully you have already got there. The QR code is going to stay with you for a minute because we are going to tell you the answer very soon. Oh, somebody's gone. Okay, the answer is, oh, it doesn't work. Let's see, pericardial diverticuly. And it was one of the cases that was presented by Dr. Madan in the presentation. And this is the end of our webinar. Thank you very much for joining us. And the next webinar will be about an update about lung grafts and lung cancer screening by Dr. Caroline Childs. Hope you are going to join us for that session, and that will be useful for everybody. Thank you very much.
Okay, we will have the QR code for the survey if you scan it and did the survey for us to improve the conference. So we will get the certification of attendance here. And that is our monthly price. Is this a watch? Okay, and
I guess we have a MSK training session, resident session
no,
next Sunday.
for radiology training. So we will see you next week, next Sunday. I will send out the flyer to your email. So and also the link to access the meeting room link. It will be MSK radiology, interesting in cases in MSK with Dr. Jason Paul, who is our colleague here at Wake Forest. So that for the training, if you have time, please join us. It's the same time next weekend. Thank you, JP.
Perfect. Thank you, Nat. And thanks everyone for joining us.
Thank you very much.
Thanks, Dr. Adil.
Thank you. And I'm going to be out.